Good morning, everyone. My name is Professor Daly, and we're going to talk about grief and loss. So, some learning objectives. We want you to be able to identify the types of losses associated with grief, discuss various theories related to understanding the process related to grief, talk about the 5 dimensions of grieving, discuss universal and culturally specific mourning rituals, discuss disenfranchised grief, identify factors that increase a person's susceptibility to complications related to grieving. We want you to discuss factors that are critical to integrating loss into life. We also want you to be able to apply that nursing process, basically your assess, do, give, teach, to facilitate grieving for patients and their families. So let's talk about grief. Grief is a very natural response to loss, right? So it's kind of thought of as emotional suffering when someone or something you love is taken away. It's really an overwhelming process if you've ever been through it or experienced it. It's a roller coaster of emotions. Some of these can be shock, anger, disbelief, guilt, profound sadness, or deep depression. It can affect not only your mental but your physical health, and that can be associated with sleep patterns or sleep hygiene, appetite, the ability to even really make decisions or think straight. These are all very normal reactions to loss, and the more significant the loss, the more intense the grief process is going to be. So the primary function of a nurse when it comes to grief and loss is to really support the patient or whoever is going through this. Sometimes it's not only the patient that you're taking care of or a patient that's actively dying, families are involved too. And families can be a little bit difficult, right? Because sometimes they don't really understand. I had a very short stretch of time as a hospice nurse. And during one of the home visits, there was a sweet little elderly lady. All she wanted to do, she was actively, she had a condition that qualified her for hospice, which meant it was a condition that would lead to a significant decline over time, right? And all she wanted to eat was basically punch bowls full of ice cream. I knew that this was okay because I was happy that she was eating it all. But her niece would come and visit her and was not happy about that. She thought it meant that, her aunt wasn't trying and that she could do better. And really, there were more nutritious type foods she could eat. But at the same time, she had terminal lung cancer. She probably wasn't going to be around very much longer. So I tried explaining at this point in time, it's quantity over quality, right? But people don't want to let go. And it was hard to support that family member because as much as you educated her, she didn't want to let go. So support can be very challenging. We really need to understand the grieving process in order to support people with it, right? We need to be culturally competent and aware. We need to offer support, teach coping skills. If that little lady wanted her punch bowls full of ice cream, I was happy to give them to her. We need to be self-aware. Are we afraid of death? Does experiencing and supporting people through grief kind of bring us back to a time that was really difficult for us? And then we need competency when it comes to bereavement. So Maslow's hierarchy of needs was probably something that you learned quite a while back, right? But if one of these needs are lost, that is a really significant type of loss for somebody, right? So these are needs that motivate human actions, right? So you start with the physiologic needs. Those are the most important, the bottom of the pyramid, the greatest. Food, air, water, sleep. Then we move up to safety. We need a safe place to live and work. Then you move up to security and belonging, satisfying relationships, right? Then we move up to self-esteem, which leads to feelings of adequacy and confidence. And then we can move up to self-actualization, the ability to realize your full potential. So let's talk about types of losses, right? So physiological, according to Maslow, this is one of the um, greatest type of losses, right? This could be amputation of a limb, mastectomy, hysterectomy for ladies. Not being able to bear children is really a significant event for a woman. Loss of mobility is really significant for everybody. That takes away your sense of autonomy, right? Safety loss. This could be loss of a safe environment. Think if your home was yanked out from underneath you tomorrow. How would you feel? This could be related to domestic violence. Then we're throwing trauma on top of that, right? Child abuse, public violence. Then we move on to loss of security and sense of belonging. So, loss of a loved one. This could also include change in relationship, birth, marriage, or death. As the meaning of a relationship changes, somebody may lose roles within a family or group, right? So even with something like a divorce, a child could lose somebody that was significant to them that they called uncle, and that can be a traumatic experience. Loss of self-esteem. This is change in how a person is valued at work, a relationship by him or herself. Death of a loved one, a broken relationship, loss of job, retirement. People don't really think of retirement as a loss, right? Everybody wants to work up to retirement. But some people, they love what they do and they're forced into retirement, and that's not easy for them. Loss related to self-actualization. This is an external or internal crisis that blocks or inhibits striving toward fulfillment and may threaten personal goals and individual potential. So this could be a really good example of this is somebody who wants to go to college or be an author, and it just didn't work out that way for them. Life had other plans. It's really a tough pill to swallow when it really becomes evident that these plans are never going to come to fruition. So let's talk about theories related to grieving. Let's talk about Elizabeth Kubler-Ross, right? So she established this basis for understanding how loss affects human life. And some of these can also be seen within a table in your book. So the 5 stages of grieving. This is something you probably have seen before. These don't have a time limit, right? They can occur, 10 minutes, or any one of them can occur at 10 years after some kind of loss is experienced. And again, it doesn't have to be a death. It could be a divorce. It could be loss of a job. A lot of different things. So there's denial, right? You don't believe it. There's shock regarding the loss. Anger. You're mad. Why me? Why did this happen to me? Why God? Why me? People can also blame relatives, friends, healthcare providers. Maybe had the healthcare provider done something differently, the loss wouldn't have occurred. Bargaining. This is where, I would give X, Y, and Z to have one more hug or more time with that person. Depression. This kind of sets in when things become real, when it hits somebody that loss is very real. And then acceptance. This is when somebody starts to cope well and come to terms with what has happened. So Bowlby's phases of grieving, right? John Bowlby, he was a British psychoanalyst. He proposed a theory related to humans being instinctively able to obtain and retain affectional bonds with significant others through attachment behaviors. These are really crucial to the development of a sense of security and survival. So His phases of grieving, pretty similar to Kubler-Ross. Numbness and denial, right? Then emotional yearning for the loved one, protesting the permanence of the loss. It still doesn't feel real. Cognitive disorganization and emotional despair with difficulty functioning. And then reorganization and reintegration. You're able to pull yourself back together and start functioning again. So again, another theory comes from George Engel, right? 5 stages of grieving. So we've got shock and disbelief. So again, you get the news that you lost your job or you lost a loved one. You're almost numb at first, and then it's hard to acknowledge. The reality is not setting in. The awareness, this is stage 2, could be involved with crying, feelings of helplessness, frustration, despair, just an emotional roller coaster, right? There could be anger, misdirected at a spiritual entity or even other individuals. Then resolution of the loss. This is when the individual is preoccupied with the loss. The lost person or object is really kind of idealized, and the individual that's mourning sometimes might even imitate the lost person. Preoccupation is eventually going to start to decline, and then the recovery phase starts. This is where all that preoccupation ends, reflection has occurred, and normal life can start again. And here we've got Marty Horowitz. This individual divided normal grieving into 4 stages of sort of loss and adaptation. So we've got the outcry, right? This is your shock. So this can be outward, screaming, yelling, crying. Some people even collapse. Or it could be internalized. But either way, this takes a lot of energy out of somebody when they first get this news. And then this is probably a pretty short-lived phase. Then there's denial and intrusion. This is going to last a little bit longer, right? So they're going back and forth between denial or being distracted or trying to distract themselves with other activities, and then kind of being obsessed with intrusion, where the thought of the loss just consumes them. Working through, this is also associated with denial and intrusion. Emotions are still really running high. They're still having that internal struggle, trying to cope, but they're starting to cope with this phase. And then completion, things start to become quote unquote normal again. Life is a little bit different, but memories are not as painful. Day-to-day life can resume, and intense feelings still might come and go, but the individual is able to function a little better. So we've got some tasks associated with grieving too, right? So there are Rando's 6 R's. So you recognize, right? This is when somebody is really experiencing the loss, beginning to understand that it's real and that it's happened. Reacting, an emotional response, right? They start to quote unquote feel the feelings. The recollect and re-experience. So this is kind of a reflection. Memories are reviewed, relived. They verbalize it a little more. Relinquish. So this is accepting that the world has changed, right? And there's no way to go back. Readjusting. This is a slow return to daily life. Losses feel less acute, a little less overwhelming, right? And then reinvesting. This is where we can really kind of hit the ground running, go back to the world, form new relationships, and start to live life again. Warden's task, right? So you accept the reality of the loss. Denial is something that's completely normal in the beginning because of the pain that's associated with the loss. But over time, um, this hurdle can be overcome. The second one here under Warden, working through the pain, right? So they have to face the loss head on. It's extremely painful, but in order to move on from something, you really have to face it head on. Then the adjustment period, right? It could take months to realize what life is going to be after the loss. Roles change, relationships are different, maybe even absent, lifestyles change, identities change, self-esteem's affected. There are, again, all kinds of feelings. Negative feelings could be inadequacy, helplessness. This is where somebody's really got to get down and dirty to develop new coping skills and adapt, right? Find a new meaning behind the loss, regain some control and start to grow. Otherwise, they can really kind of get stuck in a depressive state. And the last task here, emotionally relocate and quote unquote move on. I don't like the term move on, even though it's listed here. I don't think anybody really moves on. If you've ever lost a loved one, you cope a little better, and it's a little better to deal with, a little easier to deal with, but you're never really, quote unquote, over it. So there are different dimensions of grieving, right? Dimensions and responses. So a cognitive response. This is associated with pain that accompanies grieving that results from a disturbance, in the person's belief. This is really where nurses come in. We really have to have a holistic model of care, right? That addresses cognitive, emotional, spiritual, behavioral, and physiologic dimensions to help our patients. They might be questioning, trying to make sense of the loss, right? Why me? Why this person? Why is this happening to us right now? They want to hold on. Like I told you about my little lady with her punch bowls of ice cream and her niece, people don't want to let go even after that individual's passed, right? So the belief in the afterlife, and the belief that their loved one has become a personal guide it's a cognitive response. Emotional responses, anger. Anger is one of those 5 stages also, and it can hang around and it can be really tough. This you usually see a lot with healthcare providers. People can be very angry. You didn't do the right thing for my loved one. People can be very angry just over little things, over almost nothing after they experience loss. There are spiritual responses, right? These are deep embedded personal values that give meaning and purpose to life. So behavioral responses. So somebody could be in autopilot mode, meaning they're going through the motions of daily life, but their mind is somewhere else, right? There's sobbing, crying uncontrollably, restlessness, just different outcries of emotions. Avoiding places, or activities that were shared with the deceased, keeping or wanting to discard valuables and belongings, right? Those are all behavioral. Substance abuse, drug abuse, drinking, alcoholism, alcohol abuse. These are maladaptive behavioral responses. Physiological responses. They can be a source of anxiety and concern for the grieving person as well as for friends or caregivers. People that are grieving may have physical complaints, palpitations, anxiety, sleep disturbances. So we have to be culturally competent when it comes to providing care for patients who have experienced grief and or loss, right? Acculturation. This is altering cultural values or beliefs as a way to adapt to another culture. So basically, it's keeping an open mind, putting your beliefs aside, just suspending them for a moment, to be able to assist somebody with different beliefs or beliefs that may differ from your own. Funeral directors sometimes can discourage specific rites of passage. They can be reluctant to allow certain behavioral expressions because they can perceive them as being disruptive. There are different cultural rituals with roots in major religions. In the US, there are a lot of different mourning rituals and practices. So some cultural considerations in the African American community. The deceased can be viewed in church before the burial takes place. There are public prayers, typical black clothing, decreased social activities for Muslim Americans. There could be 5 steps of a burial procedure, washing, dressing, positioning of the body. The first step involves traditional washing of the body by a Muslim of the same gender. Orthodox Jewish Americans believe that somebody has to stay with the dying person. The body's covered with a sheet, eyes closed, burial within 24 hours of death, unless delayed by Sabbath, the practice of sitting Shiva. So the nurse's role with providing culturally competent care for individuals experiencing grief and loss really means tailoring your approach to care. It's not one size fits all. We need to encourage patients to discover and use effective and meaningful grieving behaviors. An example that's listed here, the nurse could ask a Hispanic or Latino client who is also practicing Catholic if they would like to pray with them, if they're comfortable. If a Jewish patient has just passed, the nurse could offer to stay with the body, right? While the client notifies relatives. An example that I had when working on a med-surg unit, I had a little grandma who was Muslim and she had family there. The first thing I tried to do to accommodate was her son was there and he was praying and they had to face west when they prayed, and he was on the hospital floor, and hospital floors are pretty icky, so I went and got him a blanket to lay down on the floor while he prayed. I didn't want to come out and say the hospital floor is really icky, but at the same time, I wanted to make the experience more comfortable and better for him. Also, when this little lady started to pass, we had to do our best to try to move the furniture in the room to make sure she was facing west, rather. That was part of their culture, part of their religious practices. And as the nurse, I didn't just tell them to stop moving furniture because I wanted to make sure that I was as accommodating as possible, because this was a big deal to this family, to make sure that grandma was facing the right way when she was entered into their God's kingdom. Disenfranchised grief. So, this is grief over a loss that is not or cannot be openly acknowledged, mourned publicly, or supported socially, right? So maybe an illegitimate relationship, the loss itself, it's not recognized, the griever's not recognized, the loss has a social stigma. Think about how Jeffrey Dahmer's parents felt when he passed in prison, right? This can also weigh heavily on nurses, physicians, hospital chaplains. You get attached to your patients. Sometimes these patients pass, and it's very, very difficult. The emotional effects on healthcare personnel with disenfranchised grief, they're pretty significant. Not too long ago, I believe it was a couple of years ago, remember there was a football player that collapsed on a field, and that was a really tragic event. I'm not minimizing it, but people were saying how traumatic it was for everybody at the game. And then healthcare professionals brought up the fact that, they have to watch people experience that loss all the time, and then they're just expected to function without any repercussions. So again, with the disenfranchised grief, relationships between lovers, friends, neighbors, foster parents, colleagues, and caregivers might be long-lasting and pretty intense, but people suffering loss in these relationships may not necessarily be able to mourn publicly with social support. Some relationships aren't really recognized publicly or sanctioned socially. So with disenfranchised grief, the process is more complex due to the absence of usual support for grieving or healing. In the U.S. culture here, kin-based relationships receive the most attention in cases of death. So we're going to talk a little bit about complicated grieving, right? So this is a response outside the norm, a person to avoid emotion. Grieving for prolonged periods, expressions of grief seem disproportionate to the event, right? They can suppress emotional responses due to their loss or become obsessively preoccupied. They can suffer from clinical depression when they can't make progress with their grief. There might be a pre-existing psychiatric diagnosis associated with this. Nurses have to be particularly alert to patients with a pre-existing psychiatric disorder who are grieving. This can precipitate major depression or a major depressive episode in a person with a history of the disorder. Patients can also experience grief and a sense of loss when they encounter changes in treatment settings, routine, environment, or even staff. Continuity of care is really important in the psychiatric world. The process remains unique and dynamic for each person. Again, I can't stress enough that care for patients who experience grief and loss, or even family members, is not one size fits all. So individuals who are most susceptible to complicated grieving are individuals with low self-esteem, low trust in others, or really an inability to build a trusting relationship, previous psychiatric disorders, previous suicide threats or attempts, absent or unhelpful family members. So a support system really makes a difference during a time like this. Ambivalent, dependent, insecure attachment to the deceased person. So that inappropriate attachment can sometimes cause complicated grieving. So a little more on complicated grieving. So events that involve death, and that can be considered quote unquote traumatic, extremely traumatic, right? Really can put an individual at risk for complicated grieving. So the death of a spouse or a child, a parent, right? Particularly in early childhood or adolescence, a death that was sudden, unexpected, or untimely. I can tell you when I was in nursing school, one of my clinicals, they brought a man in who I think was like 32. He was shoveling snow and just collapsed in front of his house. We did CPR on him for a long, long time, and he still passed. And as a student, they made me go with the doctor to tell the family. There was definitely some complicated grieving there because he was so young, and it was just so unexpected. Witnessing multiple deaths or being subject to multiple deaths around you. A lot of the elderly have complicated grieving because a lot of their friends and family, they've lost them, and that can be really, really tough to deal with. And then death by suicide or murder. I have a good friend, her husband suffered from depression, and he just hung himself. So she's kind of going through this complicated grieving process right now. She and her children, because that was a really serious traumatic event for them. So again, more on complicated grieving. I can't stress enough. Treating an individual or family member going through grief and loss is a very unique, varied experience for each individual. Physiological manifestations and emotional reactions can result. So this grief and loss puts stress on the body, right? And with that, you can experience an impaired immunity, increased adrenocortical activity, right? That's a stress response. Prolactin and growth hormone, psychosomatic disorders, and increased mortality from heart disease. Stress, emotional stress will put stress on your heart. Maladaptive thoughts, rumination may result. This is basically dwelling on negative feelings, right? Having that catastrophe, quote unquote, state of mind, worrying constantly about doing the right thing. There are dysfunctional behaviors, avoiding all the reminders of the deceased person, right? Or holding on to and sort of guarding possessions and pictures. There could be daydreaming about being together to the exclusion of any other coping strategies. There's inadequate emotional regulation, focusing exclusively on negative emotions, not taking a break for more soothing or calming pursuits, and ignoring regular routines for eating, sleeping, activities, social contact. These can all result from complicated grieving. So moving on to the nursing process, right? With your assessment, you want to know what that person's thought process is like at that very moment in time when they're starting to go through grief and loss. What is their cognitive function like? Are they capable of reality-based thinking or are they not, right? Do they think that person's coming back, that they may have lost, or that job is coming back? How is their emotional state? What are their beliefs, their spiritual beliefs, right? What is their behavioral like? Are they acting erratic? My friend that I mentioned whose husband just committed suicide by hanging, she was using alcohol for a little bit as a coping mechanism. That's what a lot of people fall to. Not very healthy, right? What is happening in the person's body physiologically? Are they sleeping? Are they eating? These are all necessary to cope effectively. Are they communicating effectively during the assessment? Do they not want to tell you anything, right? Again, this process is individual. There is no wrong or right way to grieve. We just want to make sure that we're giving support and supporting healthy coping mechanisms for these individuals. So some applicable nursing diagnosis here, right? Grieving, complicated grieving, risk for complicated grieving, anticipatory grieving, some outcomes, right? So these are some outcomes that would be favorable. The client is able to identify effects of his or her loss. They are seeking adequate support. They're developing a plan for coping. They're recognizing the negative effects of the loss. And they seek or accept professional assistance. These are all favorable outcomes. So again, these interventions for these individuals really include, communication is inclusive with this, right? So communication is a skill that nurses have to have, just like using, it's a tool, just like a stethoscope, scissors, gloves, anything like that. These patients trust that nurses have the knowledge and skills available to help them through whatever kind of loss they've experienced, right? So with your communication, simple, non-judgmental statements that are acknowledging and validating feelings, right? You want to refer to a loved one or objects by their name or its name. Remembering words are not always necessary sometimes. I usually discourage this with psych patients, but you really have to feel out your patient. A light touch on the elbow, shoulder, or even just being there, because it's not always appropriate to touch the psych patient, is very therapeutic for these individuals. So we want to promote coping behaviors and positive cognitive function, positive emotional function for these individuals. Adaptive denial. The client gradually adjusts to the reality of the loss through the support, really, that we give them, right? So we want to promote those coping behaviors, reviewing the strengths of the past coping, encouraging self-care, using that therapeutic communication. So, evaluation, right? We want to review the tasks and phases of grieving. They're helpful in making statements about the client's status. We need to recognize that they need support. And then you have to really, like I said, examine your personal attitudes in relation to grief and loss. So, again, your perception and belief on this subject will really dictate how you deliver care, right? You need to reflect, and then you need to really be committed to lifelong learning and ongoing self-evaluation in order to provide adequate care for individuals who are subject to grief and loss.